Hola, buenos días a todos. Bienvenidos a esta nueva edición de nuestro webinar académico desde la Unidad de Neumología y el Departamento de Ciencias Fisiológicas del Hospital Universitario San Ignacio y la Pontificia Universidad Javeriana. Bienvenidos todos y quiero darle paso a la doctora María José Fernández, que nos va a acompañar el día de hoy. Majo, bienvenida.
Muchísimas gracias a todos ustedes por conectarse y estar en este espacio académico que para nosotros es muy importante. Y bueno, el día de hoy creo que vamos a hablar un tema que es de bastante interés, que creo que a ti personalmente te gusta mucho, y es respecto a los biomarcadores y cómo influyen en el asma. Y tenemos un invitado muy especial. Quisiera darte el espacio.
Así es. Muchas gracias. Tenemos un invitado muy especial. Es el autor principal de al menos 3 estudios que fueron publicados en el 2021, 3 estudios muy importantes que probablemente cambian nuestra concepción de la enfermedad. Es el profesor Simon Couillard. Simon, good afternoon. Welcome to our academic session, and thank you very much for your time and for sharing the information of your studies.
Hola a todos, gracias Carlos, gracias María. Hablo poco español, pero voy a hablar en inglés. Gracias. Hi everyone, so really great pleasure to present to you today. I am now in Canada, but I'm going to present some work that I did when I was in Oxford. And it's a real pleasure to walk you through this exciting advancement we've been doing into biomarker stratification in asthma. The field is changing rapidly, and I hope to review at least 10 publications published in the last year, not just by me, but by others as well, that are really moving forward how we should be approaching asthma patients. So without further ado, I'll start. So I've entitled my presentation Blood Eosinophils FeNO and the Modifiable Risk of Asthma Attacks, FeNO or Fractional Exhaled Nitric Oxide. So how we can use biomarkers to identify and prevent asthma attacks. I'm now affiliated and working at the Université de Sherbrooke in Quebec, Canada, but I've just come back from two plus years in Oxford, in the University of Oxford, doing a master's over there with Prof. Pavard and Dr. Hinks. And now some of the work I'm presenting is ongoing and going into a PhD with the University of Oxford in Leiden. So again, very happy to present to you. I chose this to keep this image of a slide from one of my professors because it shows Oxford, the Oxford landscape in a very hazy manner. And I think that is kind of how we feel when we approach difficult asthma sometimes, where we see an image of someone wheezing, but we're not sure how to define it and really pin down what the problem is and what the treatable trait is. Concerning this presentation, I have no particular direct disclosure, but in the past I have had payments by pharmaceutical companies that have no link to what I'm presenting today. So our objectives, we will walk through the definition and the distinction between difficult, severe, and type 2 inflammatory asthma. We will name a few diagnostic tests which are necessary and also explore those that are optional to investigate uncontrolled severe asthma. But especially, we will do a deep dive into how and why we should be phenotyping asthma from the outset, from the point of diagnosis to the point of treatment of severe asthma. Also touch briefly upon methods to check adherence, and finally also touch briefly onto the utility of a multidisciplinary approach in difficult asthma. So my presentation is largely based on this review article that we wrote in Chest, How I Do It, Workup of Severe Asthma. You can consult that if you want, but I'm really gonna situate the findings of our 2 other articles in Thorax and in the Blue Journal that Carlos so gratefully mentioned in his presentation of mine. So let's start by a letter from the letter that, even though it's in English, I hope it relates to what you see in Colombia as well. Dear colleague, a referral letter. So please review this 56-year-old gentleman with difficult asthma. Despite current treatments, which include prescription of high-dose combination inhaled corticosteroids and long-acting beta-2 agonists, and an inhaled long-acting muscarinic antagonist, so triple inhaled therapy, he remains symptomatic and has had 4 exacerbations requiring oral corticosteroids over the past year, so 4 asthma attacks. He previously had surgery for nasal polyposis and remains bothered by nasal obstruction and anosmia. He has a dog and a cat, and his clinical examination shows wheeze, expiratory wheeze. His peak flow is 350, and a predicted value is 516. So signed by a GP, a very good referral letter, and probably often enough what we're challenged to see in the clinic. And I hope to challenge your perception of asthma and say that we should be chasing traits rather than symptoms, because all these little gummy bears might be wheezing, or they may all be sweet, but actually they all have their different little flavor that makes it unique in a different approach that might be used. And in asthma, what we want to do is try to regroup our patients and to find which traits we can actually treat. And sometimes it isn't even asthma, and we need then to focus on non-pharmacological therapy. But when they do have severe asthma, we want to pinpoint what is the inflammation component predominant in that patient. Is it allergies, atopy? Is it just type 2 eosinophilic infiltration and inflammation in the airways that might we might target with certain biologics? And is there airway infection in that case that we can just use with the usual small molecules antibiotics such as macrolides? So I'm not going to talk too much about treatment. This is really more of a investigation and workup talk, but this is the end point, is we want to find which patients will benefit from which treatments. And when we approach a patient, like the letter we just read together, we ask, our clinical approach usually should follow this kind of streamline. First, we need to ask the question, does this patient have asthma? And is that severe asthma? So is it uncontrolled? Is asthma driving the symptoms that we see or hear about? Is the environment causal or modifiable? And is there an adherence problem? If all those questions are checked, then that is severe asthma. And then we want to ask, what type of asthma does that patient have? What type of gummy bear is this patient? Has imaging been reviewed? And are further tests indicated? And no, it's not always necessary to do a lot of tests for severe asthma. So one of the first things we learn when we do a lot of asthma is that difficult asthma does not mean you have severe asthma. So asthma symptoms does not tell anything about severity, and the phenotype is independent of that. So you can have any type of phenotype at any severity of disease. And we try to divide asthma into two categories now. So depending on the presence or absence of a type 2 inflammatory process, I'll talk more about type 2 inflammation a bit later on, but we use biomarkers for that to establish the phenotype of asthma, either the blood eosinophil count with a little blood test, sputum eosinophils and induced sputum, so sputum induction, that specialist centers like in Bogota, I believe Carlos mentioned that they do it, but it's not always accessible. And FeNO, a small handheld device now that measures airway inflammation in the exhaled air content of nitric oxide. Now, what are the necessary tests for asthma workup to declare a severe asthma? It's all those that will allow to establish this criteria that we'll go into more detail, but also to rule out that this is not pseudo-asthma, so a non-asthma problem. So the only necessary investigations are those that will allow us to confirm the diagnosis, confirm the treatment is optimal, that is, that it's high-intensity treatment, that the patient is taking the treatment and taking it correctly in a good manner, and also confirming that uncontrolled asthma is driving the symptoms. And I will make the case at every point of this workup, we should be asking ourselves, what is the pattern of inflammation? What is the phenotype of that patient's asthma? So I will not go into detail in this. You are respirologists listening to me, allergists, so you know the diagnostic criteria of asthma. You know these patients should have at least a pre and post spirometry on file documenting reversible airway obstruction. But I think what we must always be wary about is to be alert that when a patient repeatedly shows non-obstructive spirometry, we should not be chasing the diagnosis of asthma anymore. We should be questioning what is the problem of the patient. And we need to challenge the fact that some patients just don't have asthma despite having a label of asthma. A methacholine challenge, I will also not go into too much detail. You know how to do these, you know how to interpret these, but it's good to repeat that this methacholine challenge is useful to exclude, but not to confirm the diagnosis. So very sensitive, but not necessarily very specific. So it's useful to exclude in patients that you don't think they have asthma, because a third of asthmatics, those that are labeled asthmatics, actually don't have asthma on further workup. And also, it's not perfect to confirm the diagnosis, because in patients with fixed airways obstruction or atopy, then it will usually be positive. So I would invite you not to ask a methacholine challenge in these cases, especially in fixed airways obstruction, because it will probably be positive in any case. So you might just be able to say that this is asthma with the fact that there's airway obstruction in a non-smoking history. So you can read this article published in 2020 about that. Now, this is where we enter the fabulous world of biomarkers. I'd like to present some very new data published in Asia by Lee and colleagues that shows how biomarkers might be useful even at the diagnostic stage. And we'll come back on this, but in essence, biomarkers of type 2 inflammation, the blood eosinophil count and FeNO, blood eosinophils and FeNO, as the higher they are, the more specific you are, the more good you are to confirm the diagnosis of asthma. A bit like nitrates on a urine dip test for a urinary tract infection. So when you see nitrates, you know it's a urinary tract infection. Well, when you see high biomarkers in a patient that wheezes, you know that's asthma. And this is a very eloquent demonstration of this. Of course, it isn't perfect. It's not sensitive. It's specific. So it's the contrary of a methylcholine challenge. If they're there, you know you're dealing with asthma. If they're not, then you need to delve a bit more. So let's do our biomarker deep dive now. Silent referendum, each in our own little corner of the world. In your initial assessment of difficult severe asthma new patient, do you use these biomarkers? Blood eosinophils, FeNO, fractional exhaled nitric oxide, total IgE plus or minus allergy testing. Now, this is where I'd like to bring you down the vision of Oxford and the vision of treatable trait doctors, and I'm sure many of you in the audience have this same vision as us. So the existential question we need to ask ourselves is, how certain are we that diagnosing asthma will actually improve symptoms and clinical outcomes for the patient? So is it the label of asthma that will improve the outcomes of your patient, or is it the process behind that you will identify and then that you will treat that will improve the outcomes? So the label of asthma isn't that important. What's important is what's driving it and what you can do in your office about it. So what are the existing useful, simple, and accessible biomarkers? I would argue that sputum eosinophils are very useful for research, but actually the blood eosinophil count, a little blood test and a complete blood count, and FeNO by a handheld device that you can have in your office and have the result immediately, are two very accessible biomarkers that you can have even in a GP practice. Now, blood eosinophils are like little bombs. They are effector cells that wreak havoc in the airways, and they are grown and matured with IL-5, which is kind of the fertilizer for eosinophils in the bone marrow. And they will go to the airways upon a chemotactic signal, which might involve IL-13, which actually induces nitric oxide synthase in the epithelium of the respiratory tract, and thus increases expiratory nitric oxide content. So FeNO is induced, FeNO is caused by IL-13 induced nitric oxide synthase in the airway production of nitric oxide, and then blood eosinophils actually are caused by interleukin-5 that increases circulating blood eosinophils. So and IL-13 and IL-4 actually communicate via the same receptor. So when you're thinking IL-13, you should usually also think IL-4 because they have kind of the same effects, which is a chemotactic effect, like a magnet pulling cells to the airways, and also giving a lot of mucus out and creating airway smooth muscle hyperplasia and contraction, which will empty stuff out if there were a parasite, for example. But luckily, parasites are rarer than asthma. And what's important to understand is the type 2 inflammatory cascade is quite complex, but it plays a role in most patients with asthma. And I will not go through all this, but definitely one should be aware that type 2 airway inflammation causes airflow limitation by multiple mechanisms. So there's different kind of components of that cascade that will cause problems, be it IL-13 mucus plugging and subepithelial thickening and edema, or eosinophilic infiltration with all the problems that it causes, and degranulation of other effector cells. Luckily, type 2 airway inflammation is detectable with clinically accessible biomarkers. So blood eosinophils I've already mentioned, FeNO, which I've already mentioned, and then IgE is a marker of allergy. So if patients have allergies, you might have total circulating IgE and specific IgE to airborne allergen. Now, our work that we did in Oxford in my master's, I'm going to take at least 5 minutes to talk through this slide. So we asked ourselves, blood eosinophils and FeNO, the numbers, what do they mean in severe asthma? So we took patients with difficult asthma that had, and I'm sorry, this is in French, I realize, that had a FeNO suppression test. So the difficult asthma was monitored remotely to make sure they're taking their inhalers. And they also, patients that had biomarker-guided treatments in randomized control trial. And then these patients were followed up for many, many weeks or years in a year in certain cases. And we knew they were taking their inhalers. And then these patients had different measurements done in their sputum and in their blood about inflammatory mediators. And they also had FeNO and blood eosinophils measured. Why did we do that? Is because FeNO is something that usually should go down with treatment. If you take FeNO, historically we said your FeNO should be down. So if your FeNO is high, you're probably not taking your inhalers. Now what we showed is if a patient is taking their inhalers and very big doses of inhalers, and they still have a FeNO above 50, then they still have very high levels of airway type 2 cytokines, chemokines, alarmins, and sputum eosinophils. So FeNO reflects the airways, and even if you have a high FeNO, you might still be taking your inhalers as well, and this patient might really have a true problem in the airways of an activated magnet pulling through effector cells homing in the effector cells to the airways. So FeNO reflects airway inflammation as assessed in sputum. And this is, of course, different than the blood eosinophil count, which really only correlates with the systemic compartment, so blood eosinophils and IL-5, serum IL-5. So both together are linked together, but they don't necessarily reflect airway inflammation. When you have a high blood eosinophil count, you know there's a lot of IL-5 circulating. But for us in this data set, when patients are taking their treatments, it wasn't necessarily correlating to the airway compartment. So two different compartments. Now, importantly, what we do know about studies in asthma, randomized control trials, we know that having a high blood eosinophil count gives you more asthma attacks. So if you have a blood eosinophil count above 0.3, you have more asthma attacks than if you had low blood eosinophils, if you are randomized to placebo. What's interesting is that if you add FeNO to the picture, you're coloring more squares. So you know that someone with a high blood eosinophil count is not that bad compared to someone that has a high blood eosinophil count and a high FeNO. So two compartments, and when they're together, these compartments identify complementary mechanisms of inflammation in asthma and problem causing. So the two together are worse than each taken alone. And so that would explain why an explosive event like an asthma attack can happen. That when you have a magnet and a bomb present, bad things will happen. So I invite you to think about FeNO as an airway magnet-like marker, and blood eosinophils thinking about effector cells, serum IL-5, the systemic pool of potential problematic cells that might cause problems to your patient. So these two biomarkers now have 3 utilities. So let's go through 3 utilities that have been established, most of them in the last year. So first, they increase the likelihood of an asthma diagnosis. So to come back on this paper, this is more than 2,000 patients that had a wheezing illness, and then they were submitted to diagnostic testing, but it also had FeNO and blood eosinophils. And what is clear is that there's a dose-response relationship. The higher the number of blood eosinophils and the higher number of FeNO, the greater the likelihood that you would confirm a diagnosis of asthma. And the combination of a FeNO above or equal 40 and a blood eosinophil count of 0.3 had a specificity of 95%, but a sensitivity of 31. So again, think about it like nitrates on a urine dip for UTI. When you see those and the patient has urinary symptoms, you know they have a urinary infection. Well, it's the same in asthma. If they have high biomarkers then and they have symptoms, then you don't need a methylcholine challenge. You know this patient has asthma. Now, the second utilities I touched upon briefly earlier, we can now measure the risk of asthma attacks if treatment is not changed in the patient in front of us. Why? Because we know data from control arms of randomized control trials across the spectrum of asthma severities. So I'm going to zoom into this because I know you're on only a half screen. So in Novel Start, a randomized control trial of mild asthma, in blue, you see the salbutamol arm, the Ventolin arm. And then in the other arms, you have the inhaled corticosteroid regimens, either fast-acting LABA or just a standard salbutamol with a mild dose of inhaled corticosteroids. And as you can see, in mild asthma, blood eosinophils tracks perfectly with an increasing asthma attack risk if you're randomized to salbutamol. So if the patient came in with salbutamol and he was randomized to salbutamol, trouble for this patient here with a blood eosinophil count above 0.3. Now, in moderate asthma, FeNO is also useful. So here you see the result from the CAPTAIN study, which was a multi-arm factorial design randomized control trial. But essentially in red here, you see the mild dose of inhaled corticosteroid containing regimens, and in green, the high dose inhaled corticosteroid. So basically we're asking the question, what is the difference between a low and a high dose of inhaled corticosteroids? And you see that according to the baseline blood eosinophil count or baseline FeNO, the risk of asthma attacks, which is the y-axis, was going up in patients that had a low dose of inhaled corticosteroids. So you want to put patients that have high biomarkers, you want to think that if you don't do anything and they have high biomarkers in front of you, well, if they were randomized to the CAPTAIN study of moderate asthmatics, they would have more asthma attacks. So that's the same perspective. And you can do this again to moderate to severe asthma in the QUEST study, in the AstraZeneca studies, and in the DREAM study of severe asthma. Every single time we measured biomarkers in patients that were submitted to placebo, things got worse for those that had high biomarkers, and things got better for those that had the anti-inflammatory treatment. So the biomarker-associated risk is independent of other risk factors because all these models are statistical models adjusted for symptoms and lung function. Also, it's important to note that blood eosinophils and FeNO confer additive risk in most of these data sets, and I'll touch briefly on that in just a second. Thirdly, all these data sets also analyze total IgE, and total IgE is not a prognostic factor, and it is not a theranostic factor. So having high IgE does not mean you will respond more favorably to a biologic or to inhaled corticosteroids, and having high IgE does not mean you will have more asthma attacks in the year under placebo. So very different. It's a very different biomarker, IgE, than FeNO and blood eosinophils. And that might be because IgE is a bit more distal in the cascade, because it's, you know, the final point of a sniper targeting allergen. So it's maybe not as disastrous as blood eosinophils or all that mucus and muscle problems that reflects FeNO. Third utility, we can now quantify the risk of asthma attacks, which is prevented by anti-inflammatory therapy. And again, I want to highlight these are all studies that were published in the last year or 2 years. So in Novel Start, patients that were on inhaled corticosteroids, a low dose, they were protected even if they had high blood eosinophils. In CAPTAIN, the higher dose of inhaled corticosteroids were protected. The excess risk was removed by anti-inflammatory treatment. In QUEST, in the AstraZeneca studies, and in DREAM, the biologics targeting type 2 inflammation would remove the excess risk. And again, I highlight that tezepelumab works especially in type 2 inflammatory populations. So it might work in type 2 low populations, but the absolute risk is a bit lower in type 2 low populations. So definitely when you take tezi, you're removing the excess risk of type 2 inflammation, definitely. Now, that's the basis for what we would like to call a treatable trait. Now, when you take all these studies I just mentioned, the Novel Start, CAPTAIN, AstraZeneca trials, QUEST, and DREAM, and you look at all the different biomarker stratum, this is what we did in our publication. We looked at all the asthma attack rates stratified by biomarkers, and then you pool them. You arrive to a pooled understanding of, in 3,000 patients, of how asthma attacks were influenced in terms of rate ratios by the high biomarkers. And sparing a few details, this is what we would like to talk about a bit more here, is that we see blood eosinophils and FeNO as the airway equivalent of blood pressure and cholesterol. I'm sure you've all seen the Framingham scale in cardiovascular disease, which is cholesterol and high blood pressure. And then there's non-modifiable risk factors by age and sex and all that. The cardiologists, what they've done brilliantly is that they've focused our attention on two biomarkers. Yes, blood pressure and cholesterol are biomarkers. They've focused our attention on that in a way that that we know that we're targeting things that we're measuring things that we can target with antihypertensive and statins. And a brilliant GP in Norway mentioned that we should do the same for asthma, and Annette Lugarit was completely right. We are able to do it with this great data set. She's on the paper as well. So when we focus our attention on blood eosinophils and FeNO, we can differentiate within the same patient so let me go into one of the islands here. Let's say we're in this island, top right island. This patient, all these patients would have had an asthma attack in the last year. They are GINA treatment step 5, so they're on the triple inhaled therapy like our patient earlier, and they have 2 or more clinical risk factors such as poor adherence, low lung function, previous ICU stay, stuff like that. But the difference is one of them has low biomarkers, a FeNO below 25 and a blood eosinophil count below 0.15. And that patient would roughly have 3 attacks in the next 4 years, 0.75 attacks per year. So 3 attacks in the next 4 years. Same kind of patient, GINA treatment step 5, 2 clinical risk factors, an asthma attack in the last year, high biomarkers, blood eosinophils above 0.3 and FeNO above 50. If they were randomized to placebo that day in front of you, they would have 3 attacks in the next year, 2.6 attacks. So this patient up right there is at a worse prognosis, and a considerably worse prognosis than the one with low biomarkers, which has a better prognosis. So again, focuses attention on something that we can measure easily, that we can treat, and also makes a good case for treatable traits as well, that will arrive in just a second. This is all based on publication level data, and I'm working on it currently in the context of a PhD to do it on individual participant data, but we're fairly certain we're onto something that is very, very valid because it's based on high quality randomized controlled trials. Now, this is also just to show you how we think about asthma. So I'd invite you to scan this QR code or visit this website that is currently in a draft version, but is going to be reworked in time for the ATS. So come to the ATS, it'd be great to meet you guys. But currently, if you scan this, you'll arrive to the Oracle it's called Oracle, the risk score tool. And you get through the questionnaires that I just mentioned. And then the case we're trying to make, and this is data that's under review currently in the ERJ Open. We'll see what happens, but we'll see if they answer favorably. But basically, patients with high biomarkers that have a bad prognosis, we show that their risk of asthma attacks, if they were randomized to placebo versus if they were randomized to anti-inflammatory treatment, be it inhaled corticosteroids, higher dose inhaled corticosteroids, or type 2 targeting biologics. So that difference in risk is actually the same as the treatment benefits in the randomized controlled trial. So the excess risk is removed by anti-inflammatory therapy, similar as if the patient was moved from one square to the lower left square. So you can reset the risk of the patient by giving good anti-inflammatory medication. But especially when you're in front of the patient, you can worry them and saying, you really should start taking your inhalers, sir or madam, because you have a bad prognosis, and we should definitely be getting more anti-inflammatory medication in you to save you bad asthma attacks. Conversely, you have patients with low biomarkers that are very worried. You can reassure them and say, actually, you have a very good prognosis with your asthma. We might be able to do other things. If you're very obstructive, we could give you another bronchodilator. If you have airways infection, we could give you a macrolide. But giving more anti-inflammatory medications will do little or close to nothing in terms of preventing asthma attacks, and it will cause you side effects. So my point in life is to give treatments that will benefit the patient and not cause them side effects. So having that framework to work with, we find it useful. And this is the calculator we kind of developed with that. And we hope to bring a more definite version, and stay tuned at the ATS. Other biomarkers. So I've talked a lot about blood eosinophils and FeNO. So this is a letter you should be aware of. In the AMAZES trial that made us all in our guidelines in every country say we should start prescribing macrolides to patients, we knew that macrolides 3 times per week or daily, they work in every kind of inflammation process if you have type 2 or type 2 low inflammation. But actually, a post-hoc analysis quite eloquently showed that they mostly work if you have chronic airways infection. So in this letter by Taylor and colleagues that is gaining in momentum and getting cited a lot, if you had H influenza on your qPCR, then you are more likely to respond to azithron blue versus placebo made a bad difference in the number of asthma attacks. And similarly, we sometimes measure FEV1, which is another biomarker, a biomarker of lung obstruction and lung remodeling in asthma. And FEV1, the lower the FEV1, well, of course, the worse you would think the prognosis of the patient is. And but actually, when you give an additional bronchodilator, such as umeclinidium, so a LAMA, you will save a few percentages of FEV1. You will improve their FEV1, but this will not reflect itself in an asthma attack difference. So asthma attacks are not sensitive to additional bronchodilators. They are sensitive to additional anti-inflammatory or sometimes macrolide therapies. That's worth keeping in mind. But definitely, if you have a low FEV1, adding LAMA, you will increase their FEV1. So that's good to know. That's really recent data by Pappy and colleagues who presented at the ERS meeting. I would challenge you as well to think differently about asthma attacks. So we should be seeing our patients more acutely in asthma. So I think we are doing a lot of patients getting steroids and antibiotics prescribed for acute asthma attacks that don't necessarily have asthma. And we have a lot of diagnostic questioning and what is the patient, does the patient have asthma or not? I would invite you to tell them, call me next time you have an asthma attack and come see me before taking steroids. And then you might be able to tease out a bit more, well, maybe this is non-asthma, their spirometry is still normal, and it definitely looks like other factors. Or maybe, well, when they're acutely unwell, they definitely have high inflammation, and then they need steroids, and they might need further anti-inflammatory treatment. And conversely, maybe when they're acutely unwell, you'll get that sputum culture finally and be able to say, well, this patient has infection and needs antibiotics. So asthma attacks are important events to promote personalized asthma management. And that's the end of the deep dive. So I hope we've been able to talk together. And my presentation isn't finished, but I'll zoom through the next of the presentation because I want to have time to discuss with you guys. But I hope I was able to convince you that all of these biomarkers are useful in a certain way. So they're all helpful to have a diagnostic aid, but especially blood eosinophils and FeNO are prognostic and theragnostic, versus total IG is mostly etiologic, to say this patient has this kind of atopic asthma and maybe should be avoiding cats. And I'd like to say also that it's not the way that we diagnose patients. It's not the fact that we know this patient has asthma that's important. It's the way we see what's the problem behind that label. So it's the inflammatory profile, the microbiome, and the obstructive pattern of the disease that determine treatment responses to anti-inflammatory medication, antibiotics, and bronchodilators, respectively. So the only necessary investigations are those that allow to confirm the diagnosis. And I would say that at this point, with all this new data coming out in the last years, that another diagnostic test that's supported is the phenotype of patient with blood eosinophils, FeNO, and allergy testing. Otherwise, we need to confirm that treatment is optimal. That's fairly straightforward. You have these different lists of high dose, moderate dose, low dose inhaled corticosteroids that you all are aware of, and you need to make sure that the patient has a good prescribed treatment. The challenge is often enough to know if the patient is taking their treatment. And oh boy, have we been fooled. No method is perfect, so use different tools for different patients. Prescription records, so seeing if the patient is picking up his inhaler at his pharmacy or his or her pharmacy, is quite simple or straightforward. It doesn't tell you anything on inhaler technique or on if they're really taking it, but if they picked up 12 inhalers in the last year, you're quite sure that they're taking their inhalers. Blood drug levels and cortisol levels are available in certain cases. So if the patient's taking theophylline, well, that's good to measure. If it's undetectable, well, there's a problem. And similarly, if they're supposed to be taking maintenance prednisone and their cortisol is normal, that's not normal. So if you're on maintenance prednisolone, you should not have a normal cortisol. You should have an abolished cortisol because you already have exogenous prednisolone being taken. The FeNO suppression test is mostly a research, but also it can be used as a clinical test where the patient has a high FeNO. So I mentioned FeNO usually alerts you that the patient's not taking their inhaler. Well, you can check that by having a patient with high FeNO come in, have a chipped inhaler, and then go away for a week or a month, or maybe 4 days, as Carlos already mentioned in the past, or many days of remotely monitored therapy. He or she comes back and you measure FeNO again, measure lung function again, measure symptom scores again. And some patients really understand better the positive impact of taking their treatments when they see a measurable decrease in their numbers, be it airway inflammation or their airway obstruction. If you see improvements in that and numbers getting better, some patients really click on that point. And otherwise, you can see as well that some patients have steroid-resistant asthma because their FeNO is still high despite everything. Of course, now if you contact your local rep, most pharma companies have different remotely chipped inhalers that they're studying, and you can check at a distance by Wi-Fi or Bluetooth how your patient's doing, and that's rapidly evolving. But that's also a very exciting aspect. So I would think we need different tools for different patients. Now, the real art of medicine starts when you need to decide what is driving the symptoms of the patient. Is it the asthma or other stuff? And this, I guess, you just need to go through the history appropriately, and maybe sometimes a few adjunct clinical tests. So occupation is very important. If you don't want to, some patients can have a disastrous natural history of their asthma if they have occupational asthma. All those environmental allergen we're keen to ask about, but when you look at the data, randomized control trials about multiple level allergen intervention, it's to eliminate household cats and put those dust filters and all that. That doesn't really decrease your treatment intensity. So the outcome of a patient killing their cat and eliminating all dust and mold in their house, it's unlikely to be able to decrease their prescribed therapy. So sometimes it's worth keeping that in mind, that maybe the occupation is very important, but maybe we're a bit too insistent sometimes on household allergen compared to what the outcomes are about taking out those household allergen. Smoking, definitely important, of course. Illicit drugs, definitely important. Pregnancy is an obvious way of checking if a patient has a good understanding of their medication. Often enough, they will stop their medications for pregnancy is associated with the loss of control of asthma. And that's bad for the fetus. So good to check at that time if they're taking their inhalers. Psychosocial stressors. Other things, of course, you're going to ask if they had an ICU in the past. And by the way, having ICU in the past usually means they were not taking their medications at that point. It's a very big odds ratio that if they had an ICU treated attack in the past, you usually don't end up in the ICU if you're taking your inhaler. So ICU, think about non-adherence, maybe investigating that a bit more, but definitely worth asking the question to see if that patient is at very high risk. The number of asthma attacks requiring corticosteroids in oral and all hospital admissions, of course, response to antibiotics, triggers. And one thing that is important that I've learned recently in my time in Oxford is the response to systemic corticosteroids can be useful to ask the patient, how fast do you respond to steroids when you start them for an asthma attack? And patients with eosinophilic type 2 inflammatory asthma will say, within the first hours or the first day of my steroid therapy, I feel really better. Patients that say they take 3 or 4 days to respond to steroids usually don't have type 2 inflammation. And that's a useful question as well to reflect to the patient, well, maybe steroids are not the tool for you. Maybe steroids are not the medication for you because you don't really respond to them. And maybe we should try other things, maybe just antibiotics, maybe just increasing bronchodilators, but with always keeping a somewhat coverage of inhaled corticosteroids. But definitely the response to steroids, if patients respond promptly, you might want to be more aggressive in looking for that type 2 inflammatory process. And if they don't respond promptly, it takes a long time. Well, then you can work on that and reflect to the patient, maybe we're overcooking it a bit with taking steroid tablets in the case of a type 2 low asthma. Areas of treatment adherence, very important to explore. Of course, I've already mentioned that. And type 2 inflammation is usually a constellation of diseases, nasal polyps, skin diseases, such as atopic dermatitis, eczema, sometimes urticaria. And of course, you want to be aware that there are red flags to check out for, ABPA if they have a history of bronchiectasis, chronic acidic pneumonia. You want at least a chest X-ray, as we'll discuss in a minute, and EGPA for vasculitis sometimes is of course something that it can be life-threatening or leave sequelae such as a stroke. So you need to ask those questions. I would argue that we should always have at least a chest X-ray in difficult or severe asthma. So maybe not in mild asthma, but in difficult severe asthma, whatever the age, you should have an up-to-date chest X-ray. And we mostly enjoy having at least one chest CT on file, but you might want to consider the age. If it's a 20-year-old female, then of course you'll wait it out a bit longer before asking for that CT. And by the way, sometimes we need to temper down the intensity of our radiologist colleagues. With raised blood eosinophils and FeNO, a certain level of mucus plugging, tree and bud, and air trapping are totally compatible with the diagnosis of asthma. So mucus plugging, tree and bud, and air trapping is compatible with the diagnosis of asthma in a certain level when they have type 2 inflammation present. So we asked imaging, spirometry, biomarkers, allergy testing. What are other tests to check? Well, 0 is often the good answer. You don't necessarily need to ask all these tests that we've detailed in our chest article. I won't go through them, but you can start asking a lot of tests in asthma. But if arguably maybe sputum cultures, I would argue that most patients that have a lot of sputum production should have a sputum culture, but we shouldn't always be looking for impossible diagnoses because it will cost a lot of investigations and the return on investment isn't always there. One important exception to the test then treat rule for alternate diagnosis is vasculitis. just to mention that EGPA or Church-Strauss, when you suspect that and it's a Friday and you ask a nerve biopsy for Monday, don't leave the patient alone without steroids during the weekend. Give them steroids, save yourself a stroke in a young patient. And definitely the biopsy will still be positive on Monday. So it's not a few days that will make a difference on a nerve biopsy, or by the way, skin biopsy isn't that good for that kind of disease. But, you know, vasculitis is probably the exception where when you think about it, you should probably be starting to prescribe steroids. Dysfunctional breathing is a very challenging part of asthma. And I just want to mention that dysfunctional breathing is like the fibromyalgia for asthma. So it can overlap with patients that have asthma. They can have a component of dysfunctional breathing. And certainly when there is type 2 inflammation, you should probably be treating the type 2 inflammation, even if you think there's a significant component of dysfunctional breathing, because sometimes type 2 inflammation just causes so much problems. When you take it out, you have a better idea of what's driving the patient's symptoms. And it is very more treatable than dysfunctional breathing, which is more challenging. You need chest physiotherapy. And by the way, this website is kind of interesting as well. Physiotherapy for bpd.org.uk for tips and exercises for dysfunctional breathing. You can direct your patients to that. Inducible laryngeal obstruction, you know all about it, I'm sure. So an inspiratory sound. Sometimes they have a lot of sensitivity to chemicals. They cleaning detergents set them off. Of course, it's diagnosed and treated with the speech and language therapist or an ENT. And sometimes this happens in exercise, and then it's a bit more challenging. But other things to stay wary of. Last but not least, the severe asthma multidisciplinary team, usually composed of nurses, a pharmacist, a speech and language therapist, always very good input to talk about the patients before the clinic, to have different people seeing the patient and making their idea and thinking about it. And finally, to review and discuss between colleagues afterwards is very helpful. And the only thing I would insist on here is that I would invite you to think about doing the adherence check on your patients before the first visit. Very easier to talk about non-adherence at the first visit, knowing it's beforehand that they only picked up 3 inhalers in the last year, than 3 visits later challenging the patient, saying, you lied to me, you told me you were taking inhalers, I see that you're not taking them. It's easier to do it on the first meeting before seeing them, having it in file, and then you just see the patient and you talk about non-adherence with them. I'll go through this. One of my 2 last slides. I hope I made the case as well that it's not all about type 2 high positive patients that you're excited to prescribe a biologic to. It's mostly about biomarker negative non-eosinophilic type 2 low patients that you can deliver the best change in care by giving them a personalized device that may decrease the number of inhaled therapies that these have. So in this patient, for example, that Prof. Favorite saw, I asked this patient if I could keep her letter anonymously and present it for teaching purposes. This patient has non-eosinophilic asthma and had a lot of symptoms, but actually when Ian saw her, he decreased her inhaled therapy. And he said, and she was very happy to be told this. She was genuinely happy that someone finally told her that she doesn't need to take all these medications because she wasn't getting any benefit from them. He mentioned to his colleague, her prognosis should be excellent. The condition is not responsive to corticosteroids in this case, and we should be alert to the possibility that some or all of her symptoms are due to factors other than bronchoconstriction. So a very good case for personalized management. So key points, MDT approach, very useful. Identify and treat pseudoasthma, that's our duty as a doctor. Adherence checks need objective tests, and objective testing are the most important aspect. Identify treatable traits such as FeNO, blood eosinophils, and airway infection, which identify a modifiable risk of asthma attacks, as I mentioned. To go back on our case, the patient before coming to see you in clinic, you reviewed the referral letter and the medical records and checked with the local pharmacy, and that patient was picking up 100% of their inhalers. And in the waiting room, the secretary passed him an ACQ score, and he had 3.2 on the ACQ score, which is high because above 1.5 suggests uncontrolled symptoms. In clinic, the patient had a good inhaler technique, a FeNO of 78, high magnet. And in the case of a patient, they're taking their inhaled steroids. Spirometry showed reversible airflow limitation with a post-bronchodilator of 72%. The history and physical exam were compatible with the diagnosis of severe adult onset asthma and comorbid nasal polyposis. And the patient states he improves less than 24 hours after starting an action pack of steroids. Diagnostic tests: when heading out of the door, you asked for a blood eosinophil count, which is 0.76, which matches the rapid response to steroids of that patient. Total IgE of 364, doesn't tell you much. Specific IgE for Aspergillus weekly positive, but the CT scan and the chest X-ray were unremarkable. So you made a diagnosis of type 2 high asthma, not ABPA. The sinus CT, you requested a sinus CT, prescribed an action pack of oral steroids so the patient could take it home and feel safe. And in the next follow-up, you're going to decide on definite treatment, aiming for remission. Because indeed, we are now talking about remission for asthma, and this is an interesting paper. So our colleagues in our rheumatoid arthritis talk about remission. Maybe we should be doing so as well in asthma. This is what we're achieving with anti-inflammatory medication. And these are the examples of ways we can knock down that inflammation process. So thank you all. I'll take questions in discussion. I left my email there if you have further questions. And I want to say in Sherbrooke, we're excited to announce we have a asthma subspecialty fellowship starting. Our first fellow is arriving in September 2022, staying for 6 months. But afterwards, we'd have an established program that we'd love to have some Colombian colleagues or anyone else looking to work and study and do research in asthma in Sherbrooke, a nice green area in Quebec. And gracias. Muchas gracias. So I will stop now.
Thank you very much, Simon, for your excellent talk. It was amazing to hear you and hear everything you had to tell us about severe asthma and biomarkers in non-severe asthma and severe asthma. And actually, we would like to discuss with you some questions that we have had from the audience. And one of them is related to the Oracle scale. It's something new and it's something amazing because you can use it on the daily basis by looking for these patients with asthma. And they want to know if this scale is useful for follow-up after adjustment of treatment, for example, with ICS, where the FeNO may already be low, but not necessarily blood eosinophils will be low.
That's a great question. So Oracle works as what we call a static prediction model. So you're in front of the patient and you measure these biomarkers and you ask these clinical questions and you arrive to a predicted risk. And then the question is, all right, so I'm going to add something to the patient and then see what happens afterwards. Well, as the question accurately highlights, as someone who had a high FeNO and you give a medication such as an inhaled corticosteroid, that should lower the FeNO. Now, then the question is, are you going to keep on chasing the biomarkers alone or see the entire picture? I think Oracle kind of talks a lot about biomarkers because independent of how the patient is in your desk, if they say they're well, but their blood eosinophil count is high, I'm not saying we should blast them with oral steroids then and there. I'm saying probably this patient, we will, in Oxford at least, we would not discharge that patient. We would take Oracle as a warning sign for this patient and say, you're still at risk, but now you're well. I'm very happy you're taking that inhaled steroid. You mustn't stop. Let's wait it out. But I want to see you again in a year's time because you're well today after we did this modification. Your blood eosinophil count is still high. That means you might still have asthma attacks. So I want to see you again in a year. So we take that as a way also, and we really do that in Oxford. So patients with low biomarkers will say, good prognosis, let's decrease the number of steroids. And then after 1 or 2 meetings, say discharge. Patients with type 2 high biomarkers, usually we will keep on our follow-up because they are at higher risk of asthma attacks, independent of the symptoms they are that day. But you need to use the whole picture, of course. And again, static. So it's a static model. So each time you need to repeat the kind of process.
Great advice. I think you have to make a mix between biomarkers and the clinical exam you're making to the patient and the medical record. And this takes me to another question that is related to biomarkers, and it's that in patients with severe asthma and type 2 inflammation with both biomarkers highs, FeNO and eosinophils, what is your approach to use these biomarkers and maybe other factors that you consider to select a biologic therapy for each case?
So that's a very excellent question. So I talked mostly about investigation, and now I'll overstep myself a bit and talk about the data of randomized controlled trials. So what do we know? If we look at Srimankar and colleagues in the Blue Journal in 2019, an analysis comparing a mepolizumab trial and a dupilumab trial stratified by FeNO and blood eosinophils. Whatever the FeNO or blood eosinophil predominant pattern of the patient, when they're under that biologic, they will always fall down to the same as a patient that had low biomarkers. So what I'm saying is the two biomarkers indicate risk, but you end up at the same square. Now, of course, dupilumab works best in patients that have nasal polyposis, atopic dermatitis, and high FeNO and or blood eosinophils. So it does, I mean, if a patient has a FeNO of 300, would I be more tempted towards Dupi? I think the effect would probably be the same between biologics, but definitely because Dupi decreases FeNO, then you might think about that. But that whole discussion is completely based on nothing, because in reality, those two patients on anti-IL-5 or anti-IL-4 will end up in the same good prognosis of asthma. So I'd like people not to overstep the data sometimes and say, well, high FeNO dupilumab. Well, actually, the data seems to say that they will all fall down in the same good prognosis. And the method of doing it is different. So in anti-IL-5, you're depleting the system of effector cells, versus in anti-IL-4, you're inactivating the airway and the epitheliums of the mucosa on the skin. You're inactivating the homing signal, so there's no more problem. So two different ways of doing it, two different effects on the biomarker levels, but in both cases, you end up with the same kind of result. I'm sorry, that's a gray answer, but that's the reality.
Oh, and I like that answer. And it leads me to another question that we have, that is like, for some patients, when they are under a biologic, they can have bad outcomes as an exacerbation. And maybe that type of exacerbation was, this type of biologic wasn't able to stop it, because maybe it was started by a different type of thing, like, for example, a bacteria or an infection, and it started like a non-type 2 inflammation, but a different one. So do you think it's important for us to use biomarkers to start understanding if their exacerbations are different and they have different type of inflammations?
Can I share my screen?
Of course.
So, where's my screen? I can't share my screen.
Okay, just give me a second. I'm gonna ask for help here. Caro, ¿podemos compartir la pantalla de Simon? Yeah, here it is.
All right, here we go. So I'm just gonna open this. So this is data for the MEX study. MEX is a study that was published in the Lancet Respiratory this year. And it was a study about patients that are treated under mepolizumab. So they are put under the mepolizumab, and then they have an asthma attack while they're under mepolizumab. And that asthma attack was highly phenotyped. It's a cross-sectional study. So this is not telling us what we should do with that attack. It just describes what kind of attack does that patient have. They measured sputum eosinophils, which, as I mentioned, is a very useful biomarker for research, especially to say what's happening at that moment in the airways and the compartment of interest. And they divided the patients that had a high versus low sputum eosinophil count, so 2 and above percentages or below 2%. And the first thing they saw is that patients with high sputum eosinophils had higher FeNO, a bit more blood eosinophils, 0.07, but mostly lower FEV1 and more obstructive physiology in general. And those that had a non-eosinophilic attack, which in this case was pretty much half of patients, so half were eosinophilic still, despite being on MEPO, they had more antibiotics prescribed and more likely to have a positive PCR to virus or bacteria. And they had better lung function. So eosinophilic attacks can still happen under mepolizumab. This does not say anything on other biologics such as dupilumab or benralizumab. But in mepolizumab-treated patients, there are different kinds of attacks still. There are still eosinophilic attacks that can happen, and these eosinophilic attacks are more obstructive in terms of lung function. Versus those that have a non-eosinophilic attack will have more airways infection. So then you might be thinking about maybe an antibiotic treatment rather than oral steroids. But that's not talked about. There's no treatment outcome in this study. And similarly, they did an analysis, a very interesting analysis about FeNO versus sputum eosinophils in the same kind, close to the same categories I just mentioned to you. And FeNO in a patient under mepolizumab who has an asthma attack, the day of that asthma attack, A higher FeNO predicts higher sputum eosinophils, quite importantly. So FeNO above or equal 50, you're definitely talking about someone who has sputum eosinophilia. So what does this mean? It means there are different kind of asthma attacks. What does this mean about treatment? We do not know yet. We do know that steroids work best in type 2. I'll stop sharing my screen if that's all right. Let's go back to the main talk. So we do know that steroids work best in type 2 inflammatory processes, but there isn't really good outcome data to say that, you know, what you should do with these things. I think we're at the stage where the next step is investigating severe asthma attacks, phenotyping them, bringing all that knowledge of chronic asthma to the acute asthma realm. And that's a research program I'm currently setting up in Sherbrooke, Canada. So that person asking the question, or if anyone wants to join in, we're going to phenotype asthma attacks of, you know, any kind of asthma, mild, moderate to severe, and ask those questions and investigate the treatment response. So I hope we can bring a question to an answer to that, and that's a very good question. And I would argue in favor of a phenotyping, but I cannot argue in saying what to do with that result.
Thank you very much, Simon. We have a question of Hernando Gonzalez, one of our fellows in pulmonary medicine. What would be the elements or markers to be taken into account to determine the therapeutic failure of biologic therapy in asthma?
So I'll tell you what we did in Oxford. First, most of the time the biologics work. All right, so more than 90% of cases you will treat with biologics, and they may still have an asthma attack then and there, once in a while, like once in a year. That would be possible, but they're no longer at 3 or more or 4 asthma attacks. So just keeping in mind, these are highly efficacious treatments. In addition to that, you do have the placebo effect on your side. So you're saying this works. So this is a great therapy. So that you save a lot of patients. If they have a bad outcome, the question is it because I took the bad decision in prescribing the treatment, or is it that the treatment is not having the biological effect that we expect? And 99% of the time, the treatment has the biological effect you expect. So what do we expect? If you have a patient on mepolizumab or an anti-IL-5 therapy, we would expect to see their blood eosinophil count be depleted and drop below 0.1. In Oxford, if someone had a blood eosinophil count 0.1 or above on anti-IL-5 therapies, we would start asking, are they taking it or they're storing it in the fridge, blah, blah, blah. But if all that is checked and they really have a blood eosinophil count above 0.1, and then we ask the question, is the asthma uncontrolled? And if it's uncontrolled, we are thinking, well, maybe this biologic is not having the good biological effect. So we use that to say, well, under anti-IL-5 therapy, the blood eosinophil count should go below 0.1. And that's largely based on the MEX data, because MEX, you had blood eosinophils of 0.07, higher sputum eosinophilia. So we think, well, maybe they're not completely depleted. So then we would change biologic. Now, the most important, so that was maybe, I'm going to take my screen here to, this is maybe this number of patients that have the lack of biological response and the lack of systematic therapy. All those that don't respond, most actually don't have asthma that's driving their symptoms. We were wrong. So sometimes you need to be able to say, well, this patient, I've burned the entire forest down. There's no more type 2 inflammation anywhere to be seen, and they're still having recurrent steroid intake. Maybe this isn't type 2 inflammation, the problem. Maybe it's something else, airway infection, dysfunctional breathing, ILO. I mean, it's always worth asking the question. So that's how we work. So we used symptomatic response, but then the biological response, and then asking what was driving the symptoms. So we repeat the process a bit. Does that answer the question?
Yeah, thank you very much.
And again, one asthma attack in a year, I mean, I wouldn't change therapy for one asthma attack in the year. I would do it for if they have another one, and I'd keep an eye on that.
Okay, so before we go, I want to ask you a question. If someone would like to look to apply for the fellowship you talk about, what do they have to do? Because I hear someone is interested about it. So
okay, so first, hi. I've just finished my fellowship, so I'm interested in setting up my own research research program. So you should write to me, s.couillard@usherbrooke.ca. I'm also on LinkedIn and all that, so you can find me. in essence, we have a fellow that's starting in September for 6 months, and she would be able, with her, we'll establish a program. So probably in March 2023, if those timelines work for you, then we will work together to see if we can find funding and get French courses. So to work in Sherbrooke, it's mostly French. If it's for clinic, then you will need to learn French. If it's just for research, we can speak in English amongst ourselves. But I have to mention the language aspect. But definitely, I would love to have, and we do have international fellows from Brazil in my hospital. So it is possible, and I know those are Portuguese. Sorry, I know. But still, we are able to. We are definitely able to do so. So you should write to me and early on, so we can start having that talk. And we're talking about asthma attacks. So what's fun is that in March 2023, I would probably have finished recruiting patients. So then we could analyze the data together. So I think it would be exciting. I think it would be fun.
Thank you.
Thank you very much, Simon. It sounds really amazing. And I know lots of people that are looking at this video will apply because they were asking this through the chat. So thank you very much for your time, and thank you for joining us and being with us. We learned lots of things, and we expect to have you in a future time talking about different things, asthma attacks and biomarkers, and hearing more about your research.
Thanks. That was really a pleasure to present, and see you in McGill, Maria, and Carlos. You better come visit. Thank you, everyone.
Okay.
Buenos
Okay.
días.
Thank you.
Hasta luego.
Bye.
Bye.